It's been about 6 months now since Dr. Zahn, my coworker, gave me a call on a Sunday afternoon, and I was blissfully working part-time, doing some volunteer work, doing some traveling. He said, "Can you come back full-time to help us because COVID really sucks?" And I said yes, not knowing exactly what I was going to get into. I don't think any of us knew exactly what we were getting into, but all of you started. I know that it was about 6 months ago that all facilities started to go on lockdown. And I didn't know a whole lot about SNFs at the time. I still have a lot to learn. But I had at the time been volunteer for my church for a local SNF where I was visiting residents every Sunday, 2 to 3 Sundays a month. And when that facility became outbreak number 4, it was, oops. Okay, I think we're on, right? Can you hear me, Genesis?
Yes, I can hear you, and I'm getting a few yeses, so I might have to
Okay,
troubleshoot offline with other people.
okay, great, thanks. And this is a new system, so thank you for your patience on this. We're going to try a couple of different things this time. So anyway, to see names on the list of infected people I know, and then to have them start to pass away, made it a very personal thing for me. There's 9 people that I know from that particular facility who have passed away, and I've seen, it really upsets me when I hear people say this is all a hoax and the people that are dying are just people who are going to die anyway. And you and I know that's not right. We know that some of the people who are on hospice, yes, they were going to die anyway. They were going to die soon. It didn't really, change their life expectancy all that much. But many of the people could have lived for many more years, many more fulfilling years. And so it's just a tragedy. And not only a tragedy that they died, but a tragedy that they died alone in many cases. And the tragedy of isolation and depression that all the other residents are having to experience because of the lockdown, all the long hours and stress that you all are feeling. I just wanted to say thank you all for continuing on the fight. Thank especially the members of our team here at the healthcare agency, our health nurses who, unlike me, didn't volunteer. I think they kind of got voluntold, but they've really stepped up to the plate. Our colleagues on expert stewardship, close members of our team who are out there every week trying to help you raise the level of your infection control practices. The UCI group that has been doing training as well on infection prevention in some facilities. And I think the partnership that we've had with licensing and certification, really appreciate Hong Nguyen and Kathleen Davidson and Anna Reynolds and the close collaboration we're having because we're really all on the same team. We're all about trying to protect your residents as much as possible, to protect your staff as much as possible. And I hope that all of you out there in the facilities see us as supportive partners in this effort. So on this Labor Day, on the 6-month anniversary of the sort of the start of the shutdown, I hope you all can have a well-deserved break this weekend. And with that being said, I will start the presentation. So, okay, hang on a second, let me get that up. Now I gotta get this down, okay. Let's start the presentation, share my screen, screen 1. Okay, good. So, oh, all right, so for the next, I gotta take the camera off, right? Hang on a second, how do I do that, Genesis? I don't want you all looking at me for the rest of this time. I just want to say hi for those of you who haven't met me before. If you haven't met me before, you probably haven't had an outbreak. So Genesis, how do I get the camera
You should
off?
have either an icon at the bottom of your screen with a camera. If not, it might be at the top of your screen where it should say end video.
Okay. You know what? I can just unplug. No, I don't want to unplug it. Let's see. I think we figured this out last time, didn't we? Ah, shoot. Should have done that before. Can you turn my camera off, Genesis? Or is it just not showing up when I have the slides up?
We do see you up at the top. Unfortunately, I cannot turn your camera on. I can mute you, but I can't turn your camera off.
Yeah, don't mute me. I think I'm the one that's supposed to be talking for the next, okay, that's not it. No. Ah, crap. Okay, I'm just gonna shut it off like this. All right. So you can see the slides now, correct?
You have them
Yeah.
minimized, but we see your screen.
All right, what happened here? Can you see them now? Are you seeing the big slide? Are you seeing the big slide now?
Yes.
Okay, thank you. What? I'm just trying to figure out how to turn off the camera. That's okay.
Okay?
It's all right.
Okay.
Right? You guys can see everything okay now?
You okay? Okay. 'Cause I was listening.
Genesis?
Yeah, I can see your screen.
Okay. All right. So we're gonna do another. Yes, we see the slide. Thank you, Arlene. Quick overview of the topics. Just an update on the SNF outbreaks. Now, in this sort of downtime over the last week and a half, I was able to update the guidance documents, and we now have a brand new web page. So you go to our ochealthinfo.com, go to the COVID section, and you will see a section for long-term care facilities and for our CFEs, residential care facilities for the elderly. So I've updated our sort of overall guidance on COVID and SNFs, as well as the closure and reopening criteria. And then soon we'll hopefully have some suggestions for what to do with returning employees after traveling. So this is what looks like, this is what our webpage looks like. So if you see that lovely picture, you know you'll be in the right place. So after going through some updates on those guidances, I will be doing some testing issues. So go over the new CMS testing guidance, some information on rapid antigen testing, and then testing of prior positives, whether they should be retested at 3 months or not. Touch on some Cal OSHA issues, COVID and flu season, and then we'll have a question and answer session at the end like we did last time. Okay, so you can see our case counts on our website. If you clicked on the desktop version, you might be able to find a graph like this, where you see that, so March is when I started. I remember testing case number 5. We're up to how many, 40,000 or so mad cases now. And things were cooking along and then started increasing. Then we had this huge spike, and we all remember this very well, right? We all don't want to have to remember it or have to experience that again. But this is, of course, when things opened up, when restaurants, businesses, bars opened up, and we had this really huge spike. And so as they closed down again, or at least restaurants and bars closed down, then things started to decrease. But it's been kind of a hard fought, right? So there's been like not quite the rapid decrease that we had the rapid increase there. And so the real question is now, is this the first wave receding? And it's really looks to me more like a spike than a wave like this, but clearly it's receding. And the question is, are we just going to be waiting for a second wave, which those of you who are surfers know that sometimes sets will take a little while to kind of roll in? Or is it the eye of the storm? So did we get this big spike because of that reopening? And now as schools are going to be reopening, that we might see another spike. So I don't know that anyone has that answer. I think we all believe that we're certainly not done with COVID and we're going to get some kind of second increase, but the only question is when is that going to happen and how big is it going to be? So in regards to SNF outbreaks, since the beginning, our first one was middle of April. We've had 56 outbreaks affecting 49 facilities. 4 have experienced second outbreaks and 3 have experienced third outbreaks. 46 of those have resolved. Now, I didn't recalculate the last time I kind of presented some data on how long they lasted. I didn't do all those recalculations because there's so many more and I had a lot of other stuff to cover. But in general, it's about the same as I presented last time. Big outbreaks, 10 or more patients, take 5 to 10 weeks to resolve, usually around 7 to 8. And small outbreaks with just a few patients can last 3.5 to 5.5 weeks, average around 4. There's been an additional 8 facilities that have had a single case or have closed temporarily while evaluating for an outbreak. And we define an outbreak as 2 or more. That's a different definition than what CMS and CDC use. I'll talk about that later. But since the beginning, over 2,000 residents have been infected and almost 1,500 staff. There have been 379 resident deaths for a case fatality rate of 18.5%. So that's actually crept up from the last time we did a webinar. And as far as I know, 4 staff deaths. I'm not sure if there have been any more since that time. I haven't heard of any more. So if your facility has not had to deal with COVID yet, congratulations. It doesn't necessarily mean that you're doing a much better job than everyone else. Luck has a lot to do with it. And I think sooner or later, everyone will have to deal with it, either in the resident, staff, or both. So updated guidance on the website is now up to 7 pages. I'm not going to go through all of that. I went through a fair amount of it last time. There's minor updates to the unit setup, PPE, and patient placement. We're just kind of emphasizing some things that maybe people didn't pick up on last time. What's new is that in the footnotes, I'm now noting the differences between our guidance and those of CDPH and or CDC. Often those two go together. And I've noted some differences in our guidance from that of Cal OSHA in the text. There's some minor updates to the PPE recommendations, a few new sections as well. So prevention of staff-to-staff transmission, which we talked about last time. Really important for you to look in those break rooms and make sure they're socially distancing, because those staff clusters oftentimes lead to an outbreak. So I'm not going to go through that again. I will touch on the visitation guidelines and then spend a lot of time on the COVID-19 testing updates. So this is pretty much the same slide I showed last time for the PPE recommendations. And what I really don't like when people put out updates and then 2 days later or 3 days later, they put out a new version. And I'm like, okay, what's changed? Like I have to read the whole thing again and find out what's different on this new update. Well, that's why I put these things in red. There's not a whole lot different, but I've put in red the things that are different from last time. So it's mostly focusing on gowns. In your red unit, extended use is still okay, although I'll talk about that a little bit more in the next slide. But if you have an outbreak in a subacute unit, we would say that extended use is not advisable. Try to go with single use and doffing those after each patient care. And then in every other place where you're using gowns, single use is ideal, okay? And so why is there this emphasis on single use gowns? Well, initially it was clearly a resource issue, right? No one could get enough gowns. And now gown supplies, I think, are getting better, that we have many places have purchased the reusable gowns. And those are really great. You can launder them and use them as many times as you want, or you can until they fall apart. Also, we know that, or we think that repeated donning and doffing episodes of used gowns, so dirty gowns, puts the healthcare worker at risk. So really the safest thing is to don a new clean gown each time you have to go and do a patient care encounter. But we're concerned for COVID, large COVID units, especially if you have 20 or 30 COVID patients, that's a lot of donning and doffing, even if you're putting on a clean gown afterwards. Taking off that dirty gown multiple times really could, put a healthcare worker at risk of getting contaminated. So the question is it safer to keep one gown on for the whole shift until you take a break? Or is it better to don and doff multiple times? And I don't know that anyone has the answer to that yet. So we're going to continue to say extended use is okay in a big unit. I think if you have a small red unit, like 2 or 3 rooms, then I would say if your supplies allow, you might want to just, instead of doing extended use, don and doff each time. But some of this change has been because of the concern for transmission of Candida auris and other multi-drug resistant organisms. We now, so that's why we're recommending to avoid the extended use in a COVID unit that's in a subacute area or it has patients with known C. auris colonization. So you'll be hearing more about C. auris. Why is it not advancing? There we go. So just wanted to touch on that briefly. There'll be an alert coming out from our agency soon. C. auris, I'm sure many of you have heard about that or heard about it last year. It's a newer type of Candida species, first appeared in OC a year ago, February, in a resident of a long-term acute care hospital, or LTAC. It was transmitted, but basically person to person, so through infected healthcare workers carrying it from one person to another, so a lack of contact precautions. But it also persists in the environment and is a little bit harder to eradicate than COVID is, so it actually requires a different type of disinfectant. In the patients, it leads to long-term colonization, but in few infections. So it's not really highly pathogenic. It's just something that's really hard to get rid of. It tends to affect trached and vented patients more often, those that have G tubes or other sort of things like that. Does not tend to affect SNF patients outside of subacute units to a great extent. It is usually more resistant to antifungals than other Candida species. The initial C. auris isolates in Orange County were resistant to azole, so like fluconazole, but susceptible to echinocandins and ampho. So it's a super bug that can't be killed. Anyway, when it was first identified, the CDC came out to help. They did some point prevalence surveys in all the 3 LTACs and the 14 VSNFs in Orange County and found that 10 of those facilities had 1 or more case and 86 total were colonized. So now, due to some recent findings, there have been increases in cases, some spread or transfer of these patients over to LA, causing some concern, likely due to extended gown use in COVID units, but more specifically in LTACs. So again, I think it's not the pathogenic thing. It's not killing 18% of the patients the way COVID is, and seeing the number of staph infections we've had, we're still going to try to do the best, do the best we can to make recommendations for what's the safest for all. But I do have some slides from last time. I love this one. My sanitizer sensei, Mr. Miyagi, just please don't forget to do the gel in, gel out, so we're not transmitting those multi-drug resistant organisms between our patients or to ourselves. So visitation guidelines. There's a recent AFL that came out that allows for indoor visitation if a facility has no COVID for 14 days, if the community cases are declining, and if adequate staffing and testing resources are available. But they do allow visiting outdoors. I think visiting outdoors is safer, and it is allowable per this AFL, even if you don't meet those criteria. So our guidance in this update is really focused on outdoor visitation, with the following safeguards: that the number of visitors are limited and by appointment only, pre-screening all the visitors. If visitors could not enter the facility, if they could be escorted to an outside area without having to traverse the facility would be the best. Face coverings worn by all, social distancing enforced so that it's monitored to make sure people aren't giving each other illegal hugs or stuff like that, unfortunately. There are some circumstances, obviously, for indoor visitation, end of life visitation. Again, I said it was just really heartbreaking to, not only the people that have died, but that they've died alone. That's just really, really hard. Urgent legal matters that need to be attended to and can't be postponed. And now the new AFL is allowing ombudsmen to come back in, whether there is an outbreak going on or not. So see the guidance for further details. So people have gotten really creative with plexiglass. And I wanted to share this nice little fishbowl from Crystal Cove. Shout out to Crystal Cove. Beautiful little wood framed plexiglass enclosed area that's on rollers so they can move it to different places. It was set up on one of their exits so that the resident could sit here in this chair and their family members could be out there at that little table. There's the little carpet, there's little plants, just really pleasant looking. So there are different ways to accomplish this. I would encourage you to just try to do your best, and maybe you won't have a fishbowl, but some way to kind of make sure that that social distancing is enforced for visitation. And this is actually an outdoor visitation. So what about dining and activities? I'm really not ready to say it's okay to do that yet. And I'm sorry, but I just have PTSD from seeing too many outbreaks that just blow through facilities and so many people die. I know people are depressed. I know they're isolated. I know they're sad. But yeah, so, if you got to do it, you got to do it, right? But do it as safe as possible. The AFL 20-22.4 states in verbatim, so I don't know what this means. One sentence says cancel communal dining and all group activities. The next one says for COVID-19 negative or asymptomatic residents, communal dining should be limited. So which one is it? I don't know. You decide. But if you want guidance, you can see that same webpage for long-term care facilities has stuff for RCFEs, and we have guidance on there for activities and dining. But realize that your residents are sicker than people in RCFEs and also sort of more densely populated. So I think the risk for transmission in a SNF is much higher than in assisted living, and people are sicker, so they're more likely to get severe disease and die from it. So just keep those things in mind. But if you're going to do it, I have a few examples. So these are both from RCFEs. People are doing creative things with tables. I like creativity. Here, 2 tables are put together. So there's like smaller tables that if you had 2 people at one of these tables, it would be too close. So now it's 6 feet here, 6 feet across. So this is a pretty nice layout, nice big room, hopefully well ventilated, maybe some windows that could be open, that sort of thing. This room's a little bit smaller, but look, they put all these tables together in this little X pattern. So now people are 6 feet across that way, 6 feet across this way. So whatever you do, just make sure you have it set up so that people are socially distanced. Now the other thing, what about salons? This is the other thing I have been dragging my feet on answering because we have had an outbreak in an RCFE that I'm pretty convinced was amplified through use of a beautician. So is it kind of worth your life to get the haircut? I don't know, but yeah. So we probably, since it's been 6 months, maybe you've been doing little bedside haircuts, but you may have residents who look like this, although probably the hair is not quite that nice looking. More likely they look like this, or maybe like this, or maybe like this. I don't know. But anyway, salons are kind of, in most places, are little small, tiny rooms in the middle of the facility that are not very well ventilated. Not excited to say it's okay to restart that, but doing it outside may be safe. So again, look at our RCFE guidance on activities for things like that. All right, so now into the heavy stuff, testing issues. Last time I did a kind of long thing on understanding PCR test results by prevalence. And I'm not going to repeat it here. I know you're all clapping for that right now because yeah, that was rather long and arduous. And for those of you who were only listening on the phone last time, it was impossible to follow. So we now do have the recording of that webinar on the website. So look at it. It's from July 30th. And that part of the presentation starts at almost minute 39. So 38 minutes, 50 seconds. And it goes through some 2x2 tables and how, results can be kind of different depending on low versus high pretest probability. So I do encourage those of you who weren't on the last webinar or who didn't get it to look at that again. It goes on for about 9 minutes, but I think it's really important to understand that not only for PCRs, but now for the antigen test, same thing. The interpretation of the test result kind of depends on the prevalence in your population. So do check that out. But the highlights are, if you're doing a test in a population where COVID-19 is likely, or there's a high pretest possibility or probability, like during an outbreak or among close contacts of COVID positive or PUIs, then a positive is likely to be a true positive. Believe it, even if the patient's asymptomatic. But a negative may not always be true. That's when you're going to maybe want to repeat, at least for a PUI, repeat that in a couple of days to really make sure that's a true result. But in a population where COVID-19 infection is not likely, if it's very low prevalence, then a positive is as likely to be a false positive as a true positive. And in that case, you may want to repeat it or discuss that with us to decide what to do about it. But a negative is likely to be true, so believe that. So in that last webinar, I said that routine weekly testing of residents is really not indicated in a non-outbreak or response-driven setting. That's where you may get more false positives than true positives. And I also said I really didn't think weekly testing of staff was required either, but now with the new CMS recommendations, that may be mandated. And that it certainly makes more sense than testing residents weekly, because residents aren't getting out and about, they're not getting exposed to anybody, but staff are doing all kinds of stuff. So speaking of the CMS recommendations, so we have this interim final rule, not sure what interim and final, how those two things can go together, but anyway, guidance for testing. That came out a couple of days ago, last week, I think. Testing the staff includes not only employees, but consultants, contractors, volunteers, students, and others who provide care on behalf of the facility, but they say prioritize those who are in the facility on a regular basis and have resident contact. So this is where I wasn't even aware of this outbreak definition, but it was also in the CDC guidance from July or something. As a single case in a healthcare worker, I don't agree with that. People are getting in the community or getting it at home, and they're saying that's an outbreak in the facility. And what about staff who work in 3 different facilities and one person causes 3 outbreaks? I'm not buying it. But certainly a nursing home onset or someone who is a long-term resident who gets it, then that's more likely an indication of an outbreak. And so this is basically the response-based testing that has been laid out before by CMS and CDPH, except that now they're saying maybe it should be done every 3 to 7 days until 14 days past the most recent result. And again, echoing the don't need to repeat a test within 3 months after the initial diagnosis. So that stuff's pretty much the same. Now we get into the differences. So the differences is before, I think CMS said weekly testing or something like that, but they allowed like the state to kind of say, or as directed by state and local public health, something like that. I didn't see that kind of flexible language in there this time. And now what it says is routine testing of staff is based on community COVID-19 activity level, as evidenced by the county testing positivity rate. Now, when I don't think those two really go together. Your county testing positivity rate kind of depends on how much testing you have available and who's getting tested, right? So if you and I called 100 friends and said, hey, go out and get tested, even if you're not high risk, then that would, and when they were able to do that, then that would probably drive our testing positivity rate down. But in counties where maybe they don't have a lot of testing available and they really have to focus on the symptomatic or higher risk people, then that testing positivity rate is going to be up. So to me, that doesn't really reflect what's really going on in the community disease-wise. Why don't they go with like, how about the number of new infections per 100,000 population over 2 weeks? That sounds to me like, okay, that would be, more like what's going on. Anyway, regardless of that, they have 3 different sort of things. There's a low, if it's less than 5%, you can test monthly, which is what you all have been doing since June, right? There's medium, where you test weekly. So that's a big jump. And then high, greater than 10%, where you test twice a week. Now, these two have little asterisks on them. And the asterisk says, this frequency presumes availability of point of care testing on site at the nursing home or where off-site testing turnaround time is less than 48 hours. So I think many of you have gotten or are getting your point of care testing things, but we're going to talk about that more in a minute. But I think very few of you have off-site testing turnaround time with less than 48 hours. Some of you do, and sometimes you're working with a lab that sometimes you get in less than 48 hours, and sometimes it takes 7 days. So they say that, and they say that if you don't have that, you have to document your efforts to get that. But then they don't say like, well, if you don't have it, then do we still have to test weekly, or can we test every other week or whatever? So I don't have the answer to that. And I talked to our colleagues from licensing and certification this morning. They said they will not, even though this guidance says that's effective immediately, there will be a new AFL coming out. And until that comes out and we get guidance from the state, that you all can just continue doing what you're doing. If you're in the surveillance mode, go with the 25% weekly. If you're in a response mode, you're supposed to be doing it weekly. And then we'll see what shakes out. But in regards to this testing positivity rate, what data do you believe or follow? So on our website, Orange County website, if you go to that, you'll see this kind of thingamajobber. And if you click on the desktop version, then you will see testing positivity rate, which 2 days ago, when I first learned about this whole thing, it was 4.9%. But then on the same day, or maybe the next day, when I went to CMS website, listed below here, it showed that Orange County was 5.1%. That's a big difference, right? We're going from monthly to weekly. So which one is it? Don't know. Let's wait until the AFL comes out. All right, new rapid antigen tests. So there's 2 types that you all are getting, the Quidel Sofia 2 or the BD Veritor Plus. There is a new one that was just FDA approved, but I'm not sure that's going to be distributed to SNFs. You are getting a machine or sometimes 2 machines and an initial allotment of tests, depending on your size or the number of patients you have. And then additional tests, once those are gone, need to be bought from the manufacturer. No idea how much those cost. About the test, you all know this is not a PCR test. It is a lateral flow assay, kind of like like the pregnancy test where you get a positive line sort of thing, but it detects part of the virus and the nucleocapsid, so an antigen test. All 3 tests require dry swab collection with no transport media, and you should test those pretty much as soon as you collect them. Everybody has to have a CLIA waiver to get one of these, but I got a list recently that showed like 60 or 63 facilities are getting them, so I guess everybody has CLIA waivers. If you don't, check out this link below. So guidance on how to use these tests. The Association of Public Health Laboratories and CDPH both came out with guidance, pretty similar. These tests are really only FDA authorized for use on symptomatic patients or PUIs, but you can order those off-label for asymptomatic individuals. Generally, they are less sensitive than PCRs. The sensitivity compared to PCR for the Quidel is about 97%, so not bad. But again, PCR is not perfect, right? It's about 80%. So you still, when you have a PUI, you get a negative PCR, you're going to want to repeat that. Same thing here. The BD Veritor is lower though, 85%. So if the test is positive though, this is a high pretest probability, right? We're testing a PUI, then we think that is true, that it's a true positive and it should be presumed contagious. No further confirmatory testing is required. And good job, Coventry Court, on doing if the test is negative, needs confirmatory PCR. One of the first times they tried it on a PUI in their facility, the antigen test was negative. They immediately sent off a PCR and that turned up positive. So good job on that, Coventry Court. So an asymptomatic individual who has that negative test, a presumptive negative, make sure you keep them in isolation until you get the PCR test results back. And both CDPH and APHL, as for now, and APHL just updated their guidance. I don't know if CDPH has updated it yet. That may be coming out, but at the time, both said do not advise use in asymptomatic healthcare workers. So not to be used for that surveillance testing or surveillance screening. But then the CDC guidance comes out, and then they kind of updated it like 3 days later. Again, bugs me. Anyway, they define 3 types of testing. Diagnostic, that's for people with symptoms. Makes sense to me. But when they say diagnostic is also for people who have no symptoms but known or suspected exposure, that to me technically is screening. But that's just technicality or whatever. Just bizarre naming. For them, screening means testing of asymptomatic people without known or suspected exposure. So asymptomatic with exposure, known or suspected, diagnostic, no known or suspected exposure, screening. And then there's surveillance, which we would be more of a public health thing to just go out there and test a bunch of people and see how much circulating virus there is in the community. So for the purposes of SNF, the CDC says you can use it for either diagnosis or screening. Not what the state and APHL says, right? However, as we said, a negative test for diagnostic purposes must be confirmed with a PCR. So according to this then, if diagnosis is also no symptoms but known or suspected exposure, like if you were going to use it for an outbreak setting where you wanted to test everyone quickly or whatever, then technically, if they're negative, you would have to confirm that with a PCR. So that seems to me like just to be kind of ridiculous and double testing. For screening purposes, though, it's all results are considered presumptive, and that basically means in a low prevalence setting, you actually may need to confirm a positive, but not a negative, and the vice versa true. So, yeah. So basically, before I leave this, I would say that, and I'll make this point later, that definitely helpful for testing PUIs. Might be helpful for testing a few staff if they skipped your routine screening thing. Maybe helpful for testing roommates when you got someone who just popped up positive to get that back quickly. But I just don't think it's a good enough test to be using really broadly in your facilities. And I'll give a little bit more on that in a bit. One other thing about these antigen tests is that now you are supposed to report those. DHHS says you're supposed to report all those test results electronically, both positive and negative. And sorry, Toby, I told you only positive. I learned about this later, so sorry to flip-flop on you. CDPH is currently, though, changing their electronic lab reporting system, and there's no estimate when that will be ready to go. And I know at least for CalReady, it was very difficult to get facilities onto CalReady for electronic reporting. So I'm guessing it would be even more technically difficult to get SNFs on. And really, we're just interested in the positive results. So what we're going to have to ask you to do as a compromise is that if you do have a positive result, we'd like to report that ASAP via phone. So either to your facility PHN liaison or to the 714-834-8180 if it's after hours. Fill out a communicable disease confidential morbidity report, a CDCMR, found at this website. It's a fillable PDF, has drop-down menus. Unfortunately, the drop-down menu doesn't even include coronavirus yet, so you'll have to type that in. Under laboratory, use the name of the machine you're using, and instead of the patient's home address, put the address of your facility and make sure your facility name is on it. So that's for positives. For negatives, we're going to ask you to track those negative results on a spreadsheet, and that will be created for your facility once you get your machines, and email that to us securely on a weekly or every 2 weeks basis, and we will promptly ignore that because basically it's a lot of work for us to put all those negative results into CalReady, but at least you can check off the box and show CMS and show whoever that you've been reporting it electronically to us, okay? So let your PHN liaison know if you've received and started using your machine, and she'll get your spreadsheet ready for you. Okay, so here's my why to stay with PCR testing of staff for surveillance or screening, however you want to call it, purposes. So most, if not all of you, are already set up for this, right? You've been doing this since June. And even though it was really difficult to start with, and there's a lot of hiccups and changing labs, and it's a pain, you're kind of doing it. You're doing it. So here's some factors to consider if you're deciding to use the rapid antigen test instead of PCR. So one factor is how long does it take for the results to get back? PCR can take a couple of days, right? Maybe a week sometimes. Rapid antigen test, 15 minutes. That one goes to the rapid antigen test. The time burden, how long does it take you to do this testing if you're doing the testing on your staff? Well, for PCR, you got to fill out your requisition, you got to label stuff, you got to take your specimen. Not a huge amount of time, depends. Some are harder than others, right? For rapid antigen test, it only takes a minute or two to collect the specimen. There's no requisition, there's no forms to fill out, but then it takes 15 minutes to run the test, and you can only do one test at a time. So you're gonna have to have people like coming in every 15 minutes to get their nose swabbed, and someone's got to be standing by that machine all day to run that. So that, to me, I'm giving that check mark to the PCR there. Okay, cost. So most commercial labs bill insurances. Many of them also bill HRSA for uninsured individuals. So there should be little out of pocket. Now, cost on the rapid antigen test, I have no idea. I tried to look it up. Of course, they won't tell you that stuff. You have to request the information. But you're getting, a couple hundred free test kits from the government, so that's good. So there's no cost out of pocket up front there. But then when you have to replace them, I don't know. So in that case, I'm getting a half check for each one because I'm not sure which side that's going to land on. Now, reporting. So labs are going to automatically report to ELR. Most of them, some of them don't. If you're using a lab that doesn't, then that's more work for you because you're having to send those results to us, and it's more work for us because then we have to put them into the system. So I'd encourage you to switch to a lab that is on the ELR. But for the rapid antigen test, you're going to have to do the reporting yourself. So I'm giving that check to PCR. And lastly, and I think most importantly, is sensitivity. So we know that PCR is more sensitive than rapid antigen test. And when you're, still have transmission going on in the community, you really want to make sure your residents are protected. So I'm giving the check there for PCR. So the final score, 3.5 for PCR, 1.5 for antigen. But your scoring may be different. So I encourage you to go through this exercise on your own and decide which one would be better for your facility. Okay, retesting of COVID positive staff. Multiple guidance documents said don't do it within 3 months, okay, because we know the test can remain positive for up to 12 months. The CDC decision memo, which came out late in July and then actually got updated in August, so it kind of changed. They first said we haven't seen any reinfections whatsoever in 6 months. So they kind of changed it around to say at this time, we do not know if anyone can be reinfected, or there haven't been any confirmed reports of reinfection within 3 months. But then just within a couple of days of that, there was a first documented reinfection in Hong Kong, which I think was like a longer one, 4 months. But then another one possible in Nevada that was just after 6 weeks. And then a few more when you see the news reports. There's not a whole lot in the literature yet, of at least good things. So in context, we've had 24 million cases worldwide to date. So only a couple confirmed or possible reinfections so far. It tells you that that's not going to be we hope it's not going to be a real common phenomenon. So we have several SNFs had outbreaks starting in April. So they are well beyond 3 months. They're into 4 months and beyond. So 2 of those have been retesting prior positives. And sometimes they've been retesting them multiple times. So I would say between those 2 facilities, probably over about 200 prior positive, either staff or residents have been tested. And only a few, about 5, have tested positive. So 3 of those on retest were negative. 1 was positive again, but had a high CT value. Now remember, the CT value or cycle threshold value, the higher it is, the lower amount of genetic material there is, the less virus stuff is there. This person was asymptomatic and had no contact with COVID. So I'm thinking this is probably someone that just, is going to be like have a little bit of positive stuff for longer than 3 months, but not necessarily a reinfection. But to be safe, we're asking them to put them in the COVID unit and just observe and make sure that no symptoms start. Then there was another one who was positive again, who was a contact of COVID positive staff, but didn't have any symptoms, but had a low CT value. So that's a little bit more concerning. Lots of virus there. That one, we sent the isolate off to the state for culture and for whole genome sequencing. So that is not back yet, but that could be a possible reinfection. We do have the initial isolate from this individual from way back in April. So if we can get the genome sequencing on the two of them, we might be able to see are they the same viruses or different viruses. Bottom line though, if you got a prior positive staff, put them back into your testing rotation after the 3-month mark. If someone pops up positive, we're happy to retest them for you to look at the CT values and try to determine what to do with them. And the prior positive residents, if it's been more than 3 months and they've been exposed to a positive staff member, test them again. What to do about those ones who go to the hospital after 3 months and come back? I feel less strongly about that, but I think probably you should put them in observation unit and retest them to make sure they didn't get re-exposed in the hospital. But like I said, I feel more strongly about the staff exposures than that. Okay, this is the same slide that I showed last time, so I just want to reiterate, not going to go through the whole thing again, that we pretty much agree with this surveillance testing and non-outbreak setting of staff. We would recommend, in general, no resident testing except for high-risk residents, mainly dialysis patients or others who leave the facility on a regular basis. Just wanted to point out, some of you back in May, I think it was, or June, we had recommended testing 25% of residents weekly. We do not recommend that anymore. So those of you who haven't gotten that message yet, you can stop doing that. All right, quickly, so just a update on the closures. Again, put sort of new stuff in red. Basically, so 2 or more you're closed. 1, it's at least a temporary closure until you get initial round of testing of all residents and all staff who cared for that resident. Then you could possibly reopen after that if you have no additional cases noted and the source of transmission is identified and has been corrected. But remember, you need to continue doing that response-based testing every 7 days. And if any further resident cases are identified, then you will be closed until you can meet the reopening criteria. Now, the new admissions. So more facilities are having new admissions test positive, and it's given me some heartburn. We initially said, oh, if they're positive at the 14 days, they probably came in with it from the hospital or wherever they came from. But now I'm just not as certain about that. So what we're saying now is if someone, develops, if they're admitted and they develop symptoms within a couple of days and test positive, that clearly they came in with it. So less than 7 days, probably not acquired in the facility. You may not need to close, but you're going to need to test staff and resident close contacts. But if it's been 7 days or more after admission, then that could be acquired in your facility. And at least one facility had several identified at that time point, and that clearly was an outbreak. So then you're going to be closed until you test all your staff and residents in the observation unit and we get all the results back and reevaluate at that point. So one other thing to consider is, and I didn't want to make this a firm recommendation, but since 14 days is just a long time, and I think your biggest risk to your residents are your staff, right? But then the next biggest risk are people coming into the facility. So I'm not saying that you should test all new admissions at 7 days, but certain situations. If you're taking someone from another outbreak facility, obviously test them at 7 to 14 days. If you're taking someone from a hospital that's having a lot of transmission going on in it, I would maybe test them at 7 to 14 days, because it's just 14 days is a long time to go, and the cat may be out of the bag by that time. So that's just something to consider. Nothing's changed here on the staff part, except I just wanted to point out that the cluster, we've had like 3 of those in the last couple of weeks, or actually it's been longer than that. So far, every cluster of staff infections that we've closed facilities for has been an indicator of an outbreak. So, if you have 2 or 3 infected CNAs who are symptomatic, there's a good chance that residents are going to be infected. Now, criteria for reopening has not really changed substantially, just clarified a little bit more, and actually is a little bit redundant here, but we want to see at least 3 rounds, the baseline 7 and 14 days. Oftentimes it's going to be more. I think we have one facility right now that's going on 15 rounds of weekly testing. And the last 2 rounds have identified no cases. The last round has to be 14 days after the last case. So that by definition means it's been at least 2 weeks since the last resident or patient case. And staff, whereas they should be tested every week, some of the really large facilities have difficulty doing that. So we'd want to make sure they're all tested within 2 weeks prior to reopening. So the one other thing is that we will advise you in writing. So sometimes a couple of facilities have, heard our team members saying, yeah, things are looking pretty good, but you need to see an email from your nurse liaison or from me, or a letter saying that you're officially reopened before you can start admitting again, please. Thank you so much. Bye. Okay, fit testing. So guidance came out from Cal OSHA that is causing some consternation, but we'll all learn from this. I didn't know that SNFs are covered under the ATD standard, the Cal OSHA aerosol transmitted disease standard. I guess you all have been since 2010, but not many of you have been having to deal with aerosol transmitted diseases. So maybe many of you have not done all the requirements for that yet. It requires annual fit testing and training if respirators are required. But now that we have COVID and respirators are required by Cal OSHA for people dealing with COVID, then you're kind of all need to do this now. And now's the time, since things are kind of calming down. There's 2 types of fit testing. There's qualitative, where you put a little hood over someone's head and you spray in or nebulize in this Bittrex, which is a bitter tasting stuff, or saccharin, and if you can smell it or taste it, then it means the mask is leaking. The quantitative is a little bit more difficult to do, requires machinery, destroys a mask, so we're not promoting that. We're going with qualitative. So in healthcare agency, we've actually done quantitative for a long time, but I asked our employee health services, does anyone have some of these test kits around? Because I had heard that facilities were having a hard time getting the test kits. And it turns out that social services agency, who's had to have fit tested about 1,000 of their employees, they have some staff members who got trained, and they trained more staff members, and they bought some kits. So they were very graciously have offered to do a training for skilled nursing facilities on how to perform qualitative fit testing. And we have 4 loaner test kits that we can hand out to facilities for temporary use to complete the initial fit testing. But then you guys do need to order your own equipment for the long term, because as you have new hires on or the annual fit testing is due again, you're going to have to do that. But at least hopefully we can help you get at least that initial hurdle over. So that training will take place the morning of September 16th. It will be virtual. Our nurses, your nurse liaisons, will be there, so they can kind of get some of that hands-on, so that when we bring the loaner kits out to your facility, they can help you troubleshoot things there. And the training will be recorded for later viewing if anyone can't make it at that time. So your nurse liaison will give you further details as the date approaches. If you do not have a nurse liaison yet and are interested in the training, please email us at longtermcarefacilityteam@ochca.com. So reuse of N95s, this is where, again, the sort of heartburn was coming in. The Cal OSHA guidance of August 6th sort of said you should be doing single use. But if you read into it more, it does permit employers who experience supply shortages to reuse and save N95s, provided that you have trained your employees effectively about how to do that and that the respirators are not damaged. So when we had a discussion with a physician from Cal OSHA, he said it's really important to make sure that facilities document this lack of availability. So who did you call? Who did you ask? What supplies did they say that they had, et cetera, et cetera. So document that and keep that documentation, as well as your documentation of your training. Have it written in your plan, like, we don't have enough N95s, this is what we're gonna do. So the bottom line is, if you don't have enough, you can follow the 5-day rotation, but you have to have your documentation in order, okay? Okay, getting near the end here. COVID-19 and flu season. So will there be flu? Most likely there is every year, so no reason to think this year will be any different. Well, when will it start? And of course, nobody knows for sure, but in prior years, it's usually around November, December when we see the first flu isolates, maybe as early as October, sometimes as late as January or so. And we do actively look for the first flu isolates. We have a number of Sentinel providers that we do testing for. So as soon as the first flu isolate is found, the word will get out. So people are asking, should we vaccinate? The answer is a definite yes, vaccinate. And if you have the vaccine now, go ahead and give it now, because since things may start as soon as October, you want to make sure your residents are protected and your staff. So people have said, is it okay to give flu vaccine to COVID positive? Absolutely. There's no problem giving the vaccine to prior COVID positive people or people who are recovering from it. If they're super sick with COVID right now, wait until they get better, just like any vaccine. You don't give a vaccine to someone who's acutely ill. Pneumovax, same thing, definite yes. If people are not fully vaccinated already, give it regardless of their COVID status. So will there be a combined influenza COVID test? Currently, there are 3 dual tests available under an FDA emergency use authorization for co-detection of both COVID and influenza. All of them are molecular tests, so PCRs are all high or moderate complexity. There are additional multiplex tests anticipated, some for rapid point of care use, but it's unclear what the supply will be like, or when they'll be available, how much they'll be, et cetera, et cetera. So the OC Public Health Lab is in the process of validating the test for dual influenza and COVID, and that should be available within a few weeks. And they will maintain their own, the single COVID test as well. So when flu hits or when flu is near, what do you need to do when someone develops a fever and cough? You do what you do now. You isolate them, and instead of just testing for COVID, we're going to test for both. Whether it's with a dual test or you have to send 2 separate tests, it'd be easier if it's a dual test. So what is that going to mean about cohorting? Well, that's going to be really complicated. And I always have to have something to talk about in the next webinar, so I'll leave that for the next webinar. So just to finish up, and don't forget our 24-hour on-call line, 714-834-8180 for asking questions, reporting anything after hours on weekends. General questions for the long-term care facility team can be emailed to this email, and our colleagues, team members with expert stewardship, their hotline or their email if you have any IP questions. And always love a good joke, even though I did this one last week. So I'm going to stop at this point. And actually, before we do questions, then Genesis is going to have a couple of polling questions. We have polling on this new thing, so we're going to see how this works out. Now, I'm going to have 2 questions. If there's a way, there's multiple people from one facility, if there's a way that maybe only one person can answer, there's a way you can figure that out. I don't know. So Genesis, what do we need to do now? Oh, there we go.
Okay, so I just opened the poll for people, so maybe we can give them a minute or so to answer. I opened the first one and then we'll open the second one after.
Is everyone, can everyone see that?
Getting a few answers, so I think they're slowly trickling in.
We're not going to keep it open for 5 minutes. Are you seeing the real time on this, Genesis? Because I'm not.
Yes.
Okay, cool.
And then once I close it, I can share the results.
Okay, let's give it about, let's give it up to a minute. So you got about 12 more seconds to vote. Has your facility received a rapid antigen testing machine yet or not? Yes or no? Is there a way, so we're going to be able to display these results here?
Yes, so should I go ahead and close it?
Yeah, go ahead and close it.
Okay, it's closed. And let me
Do I need to give you the screen back or something?
share the results.
Oh, it's like 50-50. Well, no answer. So of the ones that answered, 43 answered, 21 have it, 22 don't. Okay, interesting. All right, can we go to the second question?
Yes, I'll go ahead and open the second poll.
Okay, does your facility have a sufficient supply of N95 respirators for single use? Yes or no? Again, we'll give this a minute. So if you have your questions, go ahead and submit your questions. online, right? Genesis, we have like a little question thing there.
Yeah, you can use either the chat feature or the Q&A feature, and then we can review those.
So send your questions in now and we'll be done whenever we're done. I always block out an hour and a half for this. I never know exactly how long it's going to take. I figure if we get done early, everyone's happy, right? Okay, 5 more seconds. Genesis, why don't you go ahead and close it out?
And then I will now share.
Interesting, so pretty similar. This time we have 45 responses, 20 say yes, 25 say no. That's more than I thought. I thought there would be, of course, I think it kind of depends on whether you're having an outbreak or not, because your utilization in outbreak would go way up. All right, well, thanks. That was interesting trying that out. Any questions now?
Okay, I do see some in the chat. So the first one being, since for new admission after 7 days, it is considered facility acquired. So does that mean as well for readmission after 7 days, it would be hospital acquired?
Huh? Can you read that again?
Yeah. Let me see. Since for new admission after 7 days, it is considered facility acquired. So does it mean as well for readmission after 7 days, it would be hospital acquired?
No, it's not absolutely considered facility acquired after 7 days. Certainly if it's after 14 days, it's going to be facility acquired. What the point I was trying to make is that between 7 and 14 days, I'm just not sure. So we're going to need to do some more testing to kind of determine that. But it would be the same thing for new admissions or readmissions from the hospital.
Okay, the next question is, what is the guidance to COVID test prior to admission from the hospital? Can we request prior to admission?
Yeah, absolutely. I mean, we'd like to see those test results, 24, 40 hours before you accept them. Sometimes they're not done. I think that the prior guidance from somebody said you could do them just on admission, but you just want to get it as close to admission as possible. If the hospital refuses to do it, I think the last stuff from maybe it was CDPH kind of said that you can't refuse a patient because they haven't been tested, sort of thing, but just want to get it done as soon as possible. Oh, I'm getting a couple on chat too. I don't know if it's different than you. Someone asked for a website. Again, I'm not sure what that was. So Aura Galindo asks about elastomeric masks. Okay, so that's a good question. So the guy we talked to from Cal OSHA was a huge proponent of the elastomeric masks. He said, oh yeah, they're like easy to use, they're more comfortable, they're more cost effective, all this stuff. I don't know. I don't know a lot about them, so I don't want to opine too much on them, but it is more cost up front. You definitely would have to be fit tested. You're going to have probably a physician's evaluation before doing that fit testing, because that's kind of like a heavier thing. You do have to get replacement cartridges. And I think in a hospital setting where they have like a central supply that can decontaminate them, it probably makes sense. But do you have the ability to do all that? So the difficulty factor, I think, is clearly higher than using a particulate respirator. But the guy from Cal OSHA was a big proponent of it. And I said, okay, well, do they have like 7,000 of them waiting around? Because that's probably about how many SNF staff we have, or 10,000. He didn't have an answer for that. So certainly something you could consider. And she also asked about international travel, 14-day quarantine. Okay, that's one thing I didn't put in here. I do have some draft guidance for suggestions for what to do. Now, and that takes into consideration, and I'll email that to you, Aura, because I need to fix a link or two on it, but basically looking at where did they go? How did they get there? What did they do when they were there? So if where they went was, first of all, it's not like the CDC website's kind of wishy-washy on this, so it's not entirely clear if you should quarantine or not. But if someone went to a place where there's a lot more community transmission than we have here, or if they did particularly high-risk activities like, attended mass gatherings, or, were doing things without their masks on and stuff like that, or they're on a really long airplane flight, then you may want to consider. It kind of depends on your staffing. If you have plenty of staff and you can have that person quarantine for 14 days and then test them before they come back to work, I would do that. If you can't do that, you're going to want to monitor that person more closely, but I'll try to get that finalized and up on the website as soon as possible. But there's no good one like size fits all. It's really going to have to be on the facilities to determine based on the specifics of travel and what your staffing is like. Other questions, Genesis?
Yeah, we have quite a few. So the next one I see is there a mandate that patients cannot be discharged from an acute psychiatric facility during an outbreak?
No, people can be discharged, yeah, as long as whoever's taking them home knows that they have COVID and can monitor them.
The next question, can we perform dual testing for patients who have active COVID but are asymptomatic?
Dual testing for what? I'm not sure what the question is.
Yeah, doesn't specify. Flu.
Yeah, that's a good question. I mean, typically we think people that have flu get sick, right? Always thought the same thing about COVID initially. Good question. I'll have to think about that. I think you're thinking like in the case of an outbreak, or I'll have to talk to my lab director. I think a lot of this is we just have to learn together, right? Because we are all trotting on unknown territory. I think when flu season hits and we start to see things, we'll probably maybe initially do a round of dual testing on everybody. But then if it seems to be all COVID, we'll maybe just switch over to the COVID test. Or if it seems to be all influenza, we'll switch over to that. But I'm not entirely sure. We'll have to think about that more. Good question.
Okay, the next question being, we received a few boxes of N95s with valves from the coalition. Are we able to use these?
We really don't like those. Exhalation valves lets the virus out. I know there was something I think on the Cal OSHA thing that said it was okay, and we really don't agree with that. We'd really not like people have use exhalation valves on N95s.
The next question, is there a deadline for respirator fit testing for employees?
Good question. Not that I know of, except that I think that Cal OSHA was cutting folks some slack, realizing how busy everyone was. But it's unpredictable. When are they going to come in or could they show up at your facility? And now, so the other thing I didn't quite understand is like, when does Cal OSHA show up at a facility? Are there routine visits? Are they scheduled? Are they periodic? And basically that guy told us it's based on the complaint. So keep your staff happy. If they complain to OSHA, the OSHA man's going to show up and they'll say, hey, you haven't done fit testing yet. So I think the sooner we can get that done, the better. And like I said, since we're kind of in a lull now and it's now this time to kind of strike hard, strike fast. We're only going to have, 4 test kits. I will send the information along of how you can, order your own, but I think it could take months before that comes in. So we'll try to get that out as soon as possible. And if you could get your folks fit tested as soon as possible so we can roll those over to someone else, we'll try to get this done together.
What is your recommendation to the facility when a positive employee was testing negative after 2 weeks and on the weekly testing turned out to be positive again? Can you advise what to tell the employee?
It didn't specify how long. So positive, then negative after 2 weeks is pretty quick. That's one of two things. Well, I guess, maybe some people resolve it that quickly. I kind of have a hard time believing that because most of the stuff I've seen, people are positive for a long time. So positive and then negative after 2 weeks could be a tail end infection if that person had never been tested before. I've seen that definitely where people in assisted livings or whatever, they get tested and yeah, I had symptoms 3 weeks ago and now they're positive, negative, positive sort of thing. So hard to say, but I would say if someone is positive, negative, and then positive again, if it's within 3 months of that first positive, it's probably still residual. And as long as they're asymptomatic, I think you can ignore that.
The next question is, what if a kitchen staff continue refusing testing? Should we have the staff not come to work? What guidance should we use on this if staff refused?
Yeah, that's a great question. That's one you're going to have to answer though on the facility basis. You really just have to set the policy for your facility. And you know, everyone, CMS says, CDPH says you need to have a policy. I can't tell you what that policy is going to be because it depends on your staffing.
If a new admit from the hospital has a recent negative COVID result, do we still need to test in the facility upon admission?
No, I think if it's recent, if it's in 24 to 48 hours, you don't have to retest. But you can if you want to. I mean, I think the one thing I forgot to mention before is if you're accepting someone who had an unknown respiratory illness, who had tested negative for COVID once or maybe twice, that's someone else you may want to think about testing sooner instead of later at 7 days instead of waiting until 14. I do the 14 as well, but you know, if you have a high suspicion this person may have COVID, you may want to test them earlier.
Okay, someone else says, so since we have a lab in-house, subacute inside an acute hospital, we don't have to get a point of care testing machine. We get our antigen testing result in less than 1 day, just confirming.
I'm sorry?
I think this person wants to confirm that they
Oh.
do not have to get a point of care testing machine since they have
Yeah,
a lab in-house.
yeah, it's all that stuff was prior. I don't know how CMS was deciding who got it and who didn't. So yeah, if it's, you know, they may send you one, but my guess is that they had some prioritization scheme that are deciding who's going to get it.
The next question, do the CDPH and OC Public Health have an approved OSHA supply of N95 to give out to facilities?
You need to ask MOAC. I'm not sure. There were a number of them. We had a lot of expired N95s, which they allow us to use. I don't have no idea what the supplies are like now. So you can put in a MOAC request and see what's available.
The next question says, we are on a surveillance testing. Just clarification, shall we continue testing for employees only?
Correct. Until we figure out what this new CMS guidance means for us, just continue doing that.
The next question, just to clarify, fit testing is only for NIOSH approved respirators, correct?
NIOSH approved respirators, right? KN95s, OSHA said KN95s are not the same as N95s. I wouldn't try to fit test those. They should be NIOSH approved N95s. And it doesn't mean part of the sort of respiratory protection program is identifying who absolutely needs to have contact with the patient. So it doesn't mean you need to do that for absolutely everybody in your facility. The cooks are never going to have contact with the patients. People who are not going to be, you know, interacting with COVID patients don't need. So part of it is identifying who absolutely needs to have that and then getting an N95. So it's good to have a couple different kinds of N95s. And I know the challenge is you have one kind now. Is there going to be enough of a supply of that later? It's difficult. It's very difficult.
So I think you touched upon the next question, which is, what would you tell facilities that is fit testing KN95s?
I tell them not to do that. I wonder if it worked though. I mean, you know, this is initially, I think they were thinking that N95s were as good, KN95s were as good, but OSHA has come out pretty strongly saying that they're not. So if you got N95s, use the N95s and fit test to those.
Next question, for swabbing flu and COVID, is it just one swab or two?
For the combined test, it'll be one swab.
The next question, if you are SNF only and not LTAC or subacute, do we have to have a fit testing?
Yes, because it doesn't, you know, subacutes, I mean, it doesn't matter. It matters if you have COVID, and pretty much everyone, most facilities have had to deal with COVID. So the fit testing, according to Cal OSHA, is required if you're going to have COVID patients on site or COVID suspects, which CDPH says that you should be using N95s in the observation unit. That's one place where we differ from CDPH, but The COVID unknowns, they're saying use N95. So if N95s are required in your facility, then you need to have fit testing. You're supposed to have fit testing.
Is it required per AFL to retest previous positive individuals?
Good question. I was trying to think if anyone, they've all said you don't retest within 3 months. And I'm trying to think where they said that you should retest after 3 months. I think there was something on an AFL, and if the licensing and certification people are on or listening, maybe they can pipe up if they remember. But I think there was something that said after 3 months, you put them back into the rotation of testing, I think.
Do you have a guidance for supply deliveries to the facility? Can a delivery person come inside the facility?
If they need to, they need a mask, they need to be screened.
The next question, is there a guidance for meal trays to serve for quarantine residents? Do we have to use disposable trays?
I don't think there's anything that requires disposable trays. I mean, as long as you're like cleaning your dishes at an appropriate temperature, that should be fine. I'm pretty sure that expert stewardship is kind of looking into that stuff. So you can shoot that question off to the expert stewardship line, but I'm pretty certain you can use regular reusable trays and just make sure that they are, clean and sanitized appropriately.
CDC recommends face shields for all staff on the floor, all zones. Do you recommend this?
Yeah, that was kind of open to interpretation. That's why I had the update on the July 30th webinar on, there was actually some new things. We kind of had a discussion between expert stewardship, the UCI folks, et cetera. Certainly for red units, yellow units, absolutely necessary. For observation units, we're recommending that at least for extended patient encounters, I think, especially if there's going to be splashing or if you're doing testing, things like that, to wear it. But to wear it all the time everywhere, we don't feel like it's necessary. Is it harmful? Probably not. But I'd look at the specific. I think we did, I updated that thing on the guidance. And then for green zones, green zones in a big outbreak are really not completely green. They're kind of greenish yellow. And there we kind of leave it up to you. But a green zone and non-outbreak and stuff, do you really need to wear face shields all the time? We sort of feel like you don't have to. But the CDC guidance kind of said something like, if there's a lot of transmission in the community, well, if you got a real green zone, you haven't had COVID in a long time, then that's not a lot of transmission. So, yeah.
Okay, the next question. How do facilities decide the level of PPE conservation they need to implement? Are they informed by a health entity such as the LHD, or do they decide this on their own?
I think everyone's supposed to be sort of calculating their burn rate and making sure that you have an adequate supply. And I'm not actually sure if an adequate supply has been defined. I would say at least 2 to 4 weeks supply of things, depending on how often you're using it, and how often you're using things could change. So I think that's all supposed to be like worked out in the mitigation plan or something like that. I'm not, that's some of the paperwork stuff I'm not the most familiar with, and that may be a question for your licensing and certification contact.
After attending the N95 fit test training, will the evaluator need a competency test?
I don't think a competency test is required. So if you would like to do that, you can, but I don't believe it's required. I'll find out more. I literally just had the conference call with the folks from SSA yesterday, so more information will be coming out on that.
The next question, following prolonged post-exposure to COVID-19, was recommended by LPH to test at the 7 and 14-day mark. What's the reason for testing twice?
Because the incubation, first of all, you don't want to let something go for 14 days if someone's infected. So you test at 7 days, or you test sooner if someone has symptoms, obviously. We usually recommend a baseline testing. So once you find a case, you test right away. If everyone's negative, then you test at 7 and 14 days after last exposure, because the longest incubation period is thought to be 14 days. So you basically just try to contain the disease. we've looked at, or I've looked at some of our outbreaks in SNFs and in residential care facilities where we were testing roommates of COVID positive. And basically, I've been saying all along that 50 to 75% of them end up infected with COVID, and that turned out to be pretty close. It was like, you know, it was around 60%. And about 60% of those test positive by 7 days, but another 40% test positive out the 14 days. So that's certainly suggesting that not everyone is positive by 7 days, but you just don't want to let an infected person run around for a long time. So the sooner you can test, the better. But you also have to go out to that full 14 days to make sure that everyone's good.
Okay, the next question. What about the interstate travel staff from other state in the US, but is identified to have high COVID rate from that state?
Yeah, again, so now there's a nice CMS website that gives you county level data for the whole US. So that's again up to you. If someone, you know, went on a long plane flight to a place where there's high level of community transmission, they were out and about, they were doing, you know, mass gathering activities or social activities, then if you can have that person stay home for 14 days of quarantine and test them at the end, I would do that. But that's kind of your decision. So I will get those that guidance up on our website soon.
For new admit and readmit with history of COVID, do they still have to go to observation unit? One CDC guideline said they could go straight to regular unit.
Yeah, they can go straight to green if it's less than 3 months. The question is, what if it's been beyond 3 months since their COVID diagnosis? In that case, technically, they may be susceptible again. So like I said earlier, I don't feel super strongly about it, but probably would put those folks into the yellow, into your observation area, your new admission area, and test them just to make sure. I think in most cases that you know, is that absolutely kind of a resource issue? You know, do you have the space and stuff? But I think it's probably safer, especially now since we're starting to see a few reinfections out beyond 3 months.
Is it required per AFL to retest previous positive individuals after 3 months?
That's questions for licensing and certification. And I think it did say to put the residents, I'm sorry, not residents, staff back into the testing rotation. Is it required? That's again a licensing, like how much of this stuff is required versus recommendations. Ask your licensing and certification person.
Someone asked, can you talk a little about the COVID-19 genome sequencing and how rapidly it changes to be able to differentiate between an initial infection and a new infection?
Sorry, can you say that again?
Yes. The question is, can you talk a little about the COVID-19 genome sequencing and how rapidly it changes to be able to differentiate between an initial infection and a new infection?
Okay, that would probably be more of a question for our lab director, but I don't know like how many base pair changes is necessary to say that this is a different one. If you look back at the webinar from last month, I did show like this genetic tree, and a certain number of like usually 2 or 3 passages leads to one mutation or something like that. So I don't know the answer to that, but I could ask our lab director.
The next question says, wait for CDPH guidance regarding the positivity rate for testing that CMS recommendation.
Yes, wait for the AFL. I heard it from LNC this morning. They're going to wait for that before they're putting anything different into effect.
Okay. If you are I think I already asked this one. If testing for flu and COVID can use one specimen for both?
Yes, if it's the combined test. If you're doing 2 separate tests, then there'll be 2 separate swabs, usually. Certainly for a commercial lab, it would be 2 separate swabs. From our lab, we were able to do 2 separate tests on the same swab, but certainly if it's the combined test, it'll be only 1 swab. So it depends on where you're sending it and whether they're doing the combined or separate.
And I think that was the last question. The other question I've seen a couple of times is, will the PowerPoint be sent out?
Yes, the power, well, it'll probably be posted on our website. We could also send it out as well, but it will be posted along with, this is gonna be recorded, right, Genesis?
Correct, I have recorded it.
Okay, so that will be posted. There'll be a new sort of thing under webinars with today's date. So the PDF will be there as well as the recording. I see a couple more questions that are coming through on my thing that says about if we build a plexiglass cubicle for outdoor visitation, 6 to 8 feet distance is kept, will the resident be protected if a face shield is used instead of a procedure mask during the visitation? Good question. If you're really between plexiglass, I don't know that a face shield is going to add that much. So, you know, if they can't wear a face mask, you know, then they can't wear a face mask. At least they're six or 8 feet apart, and if you're outside, there's lots of dilution in the air. Okay. All right, thank you very much for hanging in there. Again, we'll try to do this monthly, more often if needed, but depends on how much stuff is changing. All right, hope you all have a wonderful rest of your afternoon. Have a great long weekend. Actually, our public health lab will be closed for the first time in about 5.5 months on Monday. So just so that you know that, if you're submitting specimens, hang on to them until Tuesday, okay? Take care, everybody.